great honor to be among this great panelist, actually. And thank you very much for the invitation and for the organization. It is a fantastic effort, in fairness. And good evening, everybody. Tonight, as we promised, we're gonna continue our intensive care medicine modules. And we have covered before earlier the sepsis in a full day webinar and the ERDS in a 2 days webinar. And today is the third module of intensive care, one of the hot topics, you can say, in the field of intensive care medicine. It's going to be about the acute kidney injury, and also it's going to be a 2 days webinar. So please stay tuned with us. And I'm delighted today to have very elegant speakers from international speakers from different countries. And first speaker is Dr. Ahmed Mady. And Professor Mady, I knew Dr. Mady ages ago. He is my senior, and he was teaching me during my residency in Tanta University Hospitals. And Dr. Mady has a master degree and Ph.D. in Anesthesiology, intensive care medicine from Tanta University in 2008, and Saudi Fellowship, critical care medicine in 2012. Dr. Mady is assistant professor of critical care medicine, internal medicine in 2 different universities. He is assistant professor of anesthesiology and intensive care medicine, Tanta University, and he is assistant professor of internal medicine in Al-Imam Muhammed bin Saud University in Kingdom of Saudi Arabia. Dr. Mady is a critical care consultant in King Saud Medical City in Riyadh. Dr. Mady, topic today is about the acute kidney injury, diagnosis and management, definitions, biomarkers, its prognostic value. So please, Dr. Mady, the floor is yours.
Thank you so much for this presentation. It's my pleasure to be with you here, actually, among first my professor, Prof Ines, Prof Nabil Asqalani, Dr. Yasser Zaghloul, Professor Yasser Zaghloul, and Dr. Adil, and my friends, actually. Dr. Saud, thank you so much for your great effort for spreading the knowledge worldwide. Really appreciate so much your effort, and I can feel everyone now in the anesthesia and in ICU worldwide, he knows about the mega course and he's appreciating your work. Today we will talk about the topics. Actually, it will be acute kidney injury, right? But I have another, let us say, not another talk, but we can say it another title, which is bad beans. And of course, all of you, of course, especially female, and they knows what is bad beans and how we can know our beans is bad. And so before I will start, I'd like to disclose, of course, for bad beans, I don't have any, nothing to disclose except appreciation for and thanks for my mom to teach me how to select the bad beans, how to choose the beans in correct way, of course. But if we will talk about acute kidney injury, diagnosis and the management, I have to disclose that I retrieve some of the knowledge and slides from Prof Kelam. I am an instructor actually in the multi-professional course in Saudi Arabia of the Society of Critical Care Medicine, as well as the Intensive Care Nephrology Beyond Basic, which is a collaboration between Basic Society and the European Society of Intensive Care Medicine. I'm an instructor for both, and I can disclose most of my studies related to the both societies as well as related to the both courses. So acute kidney injury and the management, we will talk today about, again, bad beans. What is bad beans? How do you know the bad beans? How is important and the epidemiology of the bad beans? And what is make beans bad? Severity, staging. How do you know that beans are bad? and how to treat or prevent the bad beans. This is for bad beans. Actually, if you will go to the proper function of the kidney to work well, it has to have three main components. First one, a normal blood flow. Second one, functional glomeruli and the tubules, the parenchyma of the kidneys has to be intact, as well as no obstruction in the outflow. So the renal blood flow has to be adequate, which is blood perfusing the kidney each minute, as well as the GFR. This is the main component function of the kidney, which is the amount of plasma filtered each minute by the glomeruli. So this is for the kidneys to work properly. Why bad beans is important? Let us have this scenario. If you look to your ICU or whatever you are working anywhere, you have common scenario of the patient which is come middle age or old age, known to be diabetic, post-laparotomy for bowel perforations, abdomen was tense and tender post-operative, she's febrile, she's hypotensive, tachycardic, tachypneic, saturations barely reaching to 91 with 5 liters of oxygen, and she's oliguric for the last 12 hours. Yesterday, she did CT for diagnosis of what she has inside her abdomen, either abscess or collection or post-operative or peritonitis. If you look to this scenario, this is common scenario in surgical ICU and also common in the medical ICU. If you look at the major risk factor as well as the main risk factor for those patients to develop the acute kidney injury, you will find more. The major chronic risk factor for this patient to develop the AKI is her age, renovascular disease, as well as his diabetic comorbidity. The acute happened in this incident to develop the AKI, her hypovolemia. She underwent a major surgery. She has probably infection in her abdomen. She received a lot of antibiotics and the medications and the nephrotoxic medication, as well as the contrast. She did CT yesterday. She's post-operative. Maybe RBS difficult to be controlled in this scenario. So those are the risk factors for this patient to develop acute kidney injury. And if you can look, some of them are avoidable. So the beauty to avoid the risk factor which can develop acute kidney injury. Why we are studying acute kidney injury? Why it is essential? If you look to the most of the studies done, not recently, a long time back, it shows acute kidney injury, one of the killer cause for the patient inside ICU. If you can imagine, 3 million people can die from acute kidney injury in these studies. Not only that, if you have 2 patients inside ICU, one of them developed acute kidney injury and the other doesn't, so the mortality will be doubled for the patient with acute kidney injury. Length of stay will be doubled in the acute kidney injury. Hospitalized patient, we have a lot of patients can be hospitalized outside even ICU, 5 to 7% they can develop the acute kidney injury. As I have mentioned earlier, mortality will be high, almost double, can reaching and ranging from 30% up to even for some studies to 65% mortality rate for acute kidney injury. So it is very essential topic to know and to diagnose early. If you go to the definition, what does it mean of acute kidney injury? Acute kidney injury is a syndrome. It is not only a spot diagnosis or a disease, it is a collection of clinical signs as well as some of lab investigations. There is no sharp definition to diagnose acute kidney injury, but ultimately you have the kidney which is lost its function, its homeostatic function. So you will find the patient who have severe reduction in renal function, in GFR and others, accumulation of nitrogenous products and uremia, azotemia, as well as retention of the fluids, and mostly have the electrolyte disturbance. So if you look to the acute kidney injury, it looks like a syndrome with clinical diagnosis, with lab investigations, with predictors you have to know, with investigations you have to do to diagnose the acute kidney injury. So the spectrum of the acute kidney injury, most of the texts they are mentioning, as I'm studying since long time back, when you talk about AKI, you have to talk about the spectrum, the classification of the etiological classification of acute kidney injury. Of course, all of us knows either we have decreased renal blood flow, which is the pre-renal cause, which is the renal cause inside the content of the kidney's parenchyma, or we have post-renal. This classification, it is in worldwide in the most of texts, if we are agree or not with this classification, but still in every text you will find this classification. The pre-renal cause, almost, we have either absolute reduction of intravascular volume, decreasing renal blood flow like the patient in hemorrhage or GI loss or dehydration, or relative reduction for intravascular volume, the patient with systemic vasodilatations, or if we can find another patient, for example, we have decreasing cardiac function, congestive heart failure, right side heart failure, all of them can cause also reduction of the pre-renal or renal blood flow. The renal, if you look to the renal causes, the most common cause of acute kidney injury is ATN, acute tubular necrosis. And mostly, if you look to the component of the kidneys from inside, you can find either glomeruli, either vascular tissues, interstitial spaces, or drugs which can cause nephrotoxics. Most of the nephrotoxics, if you look to your ICU regimen in the round, you can find many drugs you are using, many procedures you can do for the patient can cause nephrotoxicity for the kidneys. And they did find that the most important nephrotoxic medication is the combination of the multiple agents which can cause. For example, usually you are starting your patient with tazocine, vancomycin. Vancomycin in our area, because of guideline detailing, you have to cover your septic, severe pneumonia patient, septic shock patient with vancomycin and tazocine or beta-lactams. So most of our patients, whatever you have, worry if MRSA worldwide or in the ICU or not, but all of our patients, most of our patients are on vancomycin. So combination of the drugs, the most common, for example, non-steroidal itself, maybe it will not cause, but if they're combined with another nephrotoxic drug, it can cause acute kidney injury. Another factor, which is glomerulonephritis, TTP, HUS, infective endocarditis, vascular disease, as well as also interstitial parenchymal lung disease, either drug-induced or infection. So this is the renal spectrum of the acute kidney injury. If this is the least causes, which is almost in the post-renal, because you have to have both ureter obstruction, which is the least one, right? So this is the almost considering about 5% of the acute kidney injury with the post-obstruction, post-renal acute kidney injury. Really, I don't like to go to this classification, and I feel it is fair, it's not fair to give this classification. Why? Because, for example, you can find a patient with congestive heart failure. You will consider him as a perennial cause, but actually, her encapsulated kidney can be enlarged, it can be congested because of high congestion of the acute kidney injury. So we have also parenchymal lesion, parenchymal cause. Sepsis, for example, sepsis can cause parenchymal. If you classify it as a renal cause for acute kidney injury, yes, but it can cause also relative vasodilatations. It can cause also pre-renal. So I think it is interacting, it is overlapping classifications. So I'd like to go with the what we are doing actually, and I appreciate so much the moderators and the organizer of these sessions, because they are coming to the updated, they are coming to the syndromes. Acute kidney injury is the syndromes. We have cardiorenal syndrome, we have hepatorenal syndrome. It will be touched by our guest, our friend, our speakers in these webinars. So it is not solid classifications, pre-renal, renal, or post-renal. No, we have a lot of mechanisms can be combined: ischemia plus perfusion, inflammation plus toxins, glomerulonephritis, nephrotoxins, and the most of them coming in the proximal tubules. Also can be happening in distal, but the most of them in the proximal tubules. So I do like actually to go with the syndromes, to go with the clinical syndromes. You can have patient with nephrotoxic acute kidney injury, sepsis-induced acute kidney injury, cardiorenal syndrome, hepatorenal syndrome, and we will go through each, most of them, the most common of them, with in this webinar. Right. So if I go through the one of the polls we have now, I will ask you, inside ICU, which of the following is the most common cause of AKI inside ICU? Epidemiology of the AKI inside ICU. So is it hypovolemia? Is it abdominal compartmental syndrome, ischemia, sepsis, hepatorenal syndrome? The question number one, kindly you can go to the polls, first poll, and you can start to vote. Which of the following is the most common cause of acute kidney injury inside ICU? Not outside ICU, because epidemiology will be different. You can start voting. Hello? Or you can send in the chat room, no problem. If poll not working, you can send in the chat room. Dr. Tharwat, my voice is clear, and yes, because no one responded. I think they start to respond now. Okay, they start to have respond now in the chat room. Great.
Yeah, it is in the chat room, Dr. Ahmed.
Yes. Okay. No problem. It's okay. So most of you responding with the sepsis. We still some minor. Some of you have hypovolemia, sepsis. So I think most of you have the proper answer. If you look to the patient inside ICU, we are assuming he has hypovolemic, but really not. Look to your patient. Anyone can prescribe fluid for the patient inside ICU. Apparently, you feel he's hypovolemic, but in real, if you calculate his balance, he will be hypervolemic, most of them. So hypovolemia, it can be happened, and it is very harmful for the kidneys, but still, hypervolemia can be happened also inside ICU, which is more. Compartmental syndrome, yes, it can be happened, but it's not the common cause. Really, yes, sepsis is the most common cause. Actually, you can find the patient coming in sepsis presented with acute kidney injury. 50% of them presenting with acute kidney injury. Sepsis is the most common cause of the acute kidney injury inside ICU. If you look outside ICU, yes, you can think about nephrotoxic medications. You can think about hypovolemia, is presenting it. You can think about another causes. But inside ICU, sepsis. Many patients coming with acute kidney injury as a first presentation of sepsis. And in sepsis, it is a syndrome inducing acute kidney injury. And everything can happen in sepsis. Hemodynamic derangement, biomarkers increasing, laboratory values changing, mechanical ventilations, most of the medications, induce sedatives, narcotics, everything can happen in sepsis, can cause more inducing acute kidney injury. So sepsis is the most common cause of the AKI in the ICU. How we will diagnose? How we will detect your patient in AKI earlier is better to prevent it. If we go to the systematic assessment or diagnosis for the patient in AKI, first go to the spectrum of AKI. Does he have any disease? I prefer to go with the syndromes. What syndrome he has? Sepsis AKI, hepatorenal, cardiorenal, compartmental syndrome, rather than going for the renal or post-renal. If you will go with the indices to diagnose my patient hypovolemic or hypoperfused or have parenchymal injury in the kidneys, so we'll go with the urine indices, fractional excretion of sodium, fractional excretion of urea, urine osmolarity or urine sodium, to just detect it is abnormal. It is not solid. We still have a gray zone for these indices, of course, because the etiology overlapping between both of them, as well as the pathophysiology can be overlapping. But it can give you a hint about, does my patient have perirenal or post-renal or renal injury? Unfortunately, what we are relying on, the renal function with creatinine and urea, are crude markers for renal function and GFR. You can see it in these studies. You need to reduce GFR so much for the urea and the creatinine to go higher. So it is not sensitive marker. It is not early predictor for the patient acute kidney injury, even we are relying on. So you need to go with the severity. Of course, all of you know about Rifle criteria, about EKN, about KDIGO style, KDIGO classification of that. The idea behind to know, to stratify your patient, to staging the acute kidney injury, is it in the risk? Is the kidney at risk, or it is injury already, or she's in failure now? And we are talking about acute. So we are talking about the 3 stage of EKN, right? So simply, it is at risk. It means the stage 1 of EKN, it means almost, we still don't have a clear or solid evidence of parenchymal injury of the kidneys. Once you have parenchymal injury, we are in the injury stage. We are in the stage 2 of the EKN. Even with the advanced biomarker, they found in the risk stage, in the stage 1, there is almost 50% of those patients have parenchymal injury. And we have the 2 markers we are relying on is creatinine and urine output. As you can find it rising creatinine 1.5 early, or 0.3 milligram per deciliter, and you have to mention within 48 hours. Within 40 hours, 48 hours, not from the ICU admission, not from the hospital admission, no, from the baseline. If you have the patient with chronic kidney disease and his creatinine is normal 2, if he's rising 2.4 within 2 days, he's in acute kidney injury on top of chronic kidney disease, as well as urine output. So you have to stratify. Staging also, it is predicting, it is give you clue about the outcome. Of course, the higher stage, the worse outcome. So we are staging to classify, to know which stage our patient in acute kidney injury. It is in injury stage. Still, we don't have a parenchymal lesion in the rifle risk stage, or already most of the hair parenchymal injured, or in the failure stage, more urine output. A very nice study also by Kelam. He stratified the main 2 components of the classification, which is urine output. If you look here, urine output only, this is over 32,000 patients. He published it in Journal of American Society of Nephrology. This is the first marker, urine output, as you can see it here in the x-axis. In the y-axis, you can find only creatinine with classification. So the beauty here, if you have the patient here, the green one with normal, both urine output normal and the creatinine is normal, so we don't have acute kidney injury, we don't have RRT. So we don't have any, either no patient, 4% will die, or no dialysis will be done for those patients. But if you go diagonal until the dark red on the corner here, you can find 55% patient, half of the patient will be dialyzed, half of the patient will die. Why? Because we have the 2 markers changing in the stage 3 of both of them, urine output as well as the creatinine. Not only that, the beauty of this study, just look to the urine output only as a marker with normal create. You can find the stage 3, 17% of the patient will die. So we still have the patient at stage 3 of urine output with create normal, we have higher mortality rate for them. Even higher than the stage 3 of create only without urine output. It doesn't mean the urine is more sensitive than the create. Both of them are not sensitive, but we can rely on a little. As we know, creatinine can take time. It can grow up late. It can be filtered late. So creatinine can rise in late. When we combine both, sensitivity would be higher. So still, both of them are not robust markers, but combined both of them, yes. We can rely on urine output in early stages of the acute kidney injury. As you can see it here, still some patient can be dialyzed with no urine output. Right? But mortality is really, it is very good findings to find it. So combined both, higher predictive mortality and the higher sensitivity, even urine output can rely on. So if we will relying on both of them already late, so they try to find biomarkers which can detect early the severity of injury of the kidney. Those biomarkers looks like alarming, like smoke of the fire. For example, if we will go to the sun, which this example said by Kelam in his lecture, right? The ultraviolet rays, the epithelium of the skin will start to have some changes before cycle arrest, before apoptosis, before cell necrosis. Some biomarkers will be degenerated, giving you a clue about your skin is in danger. This is exactly what will happen in the kidney of the proximal tubules, of the endothelium, of the epithelium of the proximal tubules. Many biomarkers will be released early, giving you clue. Within 12 hours, almost within more than that, your kidney are in danger. And they start to measure those biomarkers to check which one will be sensitive to give us clue about which one of my patient. This is called cell cycle arrest. They did found the most common 2 biomarkers, which is in high area under the care of high sensitivity, is tissue inhibitor of metalloproteinases 2 and insulin-like growth factor binding protein 7. Both of them, they are releasing earlier, 12 hours almost, and they can give you a very good predictors of the AKI, even before creatinine will go high, even before your output will be high. A very good study, they published it to assess which biomarkers worldwide. They divided into two studies, discovery and the validation study. Discovery, they almost went through, they said most 300 biomarkers in the kidney injury. And they conclude in the discovery, we have the best two biomarkers, which is, as we have mentioned early, insulin-like growth factor and tissue inhibitor of metalloproteinase. And they studied those two biomarkers extensively. And they did found it of most, they can predict stage 1, 2, or 3 of the AKI in earlier 12 hours. So they are very good biomarkers, and you can find, they compare them with the most of the biomarker we have, like interleukin 18, like kidney injury markers, like liver fatty acid binding proteins, like neutrophil gelatinase associated. All of these are biomarkers, but if you look, if you are checking in the urine, the most two sensitive with area under the curve reaching to 0.8, tissue inhibitor of metalloproteinases and insulin-like growth factor binding protein 7s. Both of them, we have entered the curve of almost 8. More predictor and more assessment of the acute kidney injury in advance. So this is the two biomarkers can give us clue. You can use it. Actually, our clinical practice, we are not using, but in their literature, they are using it by default in their hospital, even as a surveillance for the acute kidney injury in the world. And they found the figure of 0.3 and more, we have relative risk of 4.2. The higher the figures, more than 2, 17% of the relative risk. So the higher, the more risk, the higher risk. Less than 3, relative risk index of 2.7 only. So they are relying on these two biomarkers in the urine to check your patient going to AKN sooner. So the bottom line, urine, insulin-like growth factor binding protein 7 and tissue inhibitor of metalloproteinases perform better than existing markers from predicting the development of moderate to severe KDIGO within 12 hours of sample collection. Risk of major adverse kidney events like CRRT, like composite death, like dialysis, like dysfunction of the kidneys within 30 days elevated sharply when you find those markers above 0.3, as we have mentioned early. If more than 2, risk factor reaching even to 17%, very high, significantly high. So they are relying on both. What will happen for your patient in AKI if the relatives asking you about, and they're almost concerning about the kidney, they are so much worried about the kidney of their patients. He will do dialysis, he will be stay for dialysis for longer life. What you will answer them? Your patient developed AKI, how is his recovery? How is his recovery from AKI? Very nice study done on 16,000 patients of AKI. They found almost 2/3 of them will be recovered within 7 days. But don't be happy, because those 60% were recovered within 7 days, they still have the probability of reversal again of developing again acute kidney injury. So you have to wait at least for 3 days to confirm your patient is recovered from AKN. So if the patient developed AKN, so within 7 days, 60% of them can recover within 7 days, but still those patients can have relapse again. 14% of them can have relapsing, and 26% of them can be persistent for recovered, and some of them can have some relapse and recovery again. So you have to wait. Don't disclose for the families that your patient recovered from AKN unless past 2 to 3 days with persistent biomarkers, with persistent normal creatinine and urine output and no support. Even the patient who didn't recover early from AKI still have the chance of some of them who can develop again recovery after that later on. So the message here, you have to wait to assess, to judge your patient he recovered from AKI or not. Still have 2/3 of them can be recovered, but still have a relapsing portion of them we can happen later on, right? So this is the phenotyping of the patient of AKI, what happened for them. So if I have my patient with acute kidney injury, acute, within this 7 days now, all of us know those patients, whatever creatinine is high or urine output is low, if he stays for more than 3 months, so he will be chronic kidney disease. This we know that. But what can I name those patients if he's still in the acute kidney injury more than 1 week, within 2 weeks, within more? Right? So we can call him acute kidney injury and processing to chronic kidney disease, but really we're naming them now as acute kidney disease. So the patient in early stage acute kidney injury, the patient after 90 days his chronic kidney disease, the patient acute kidney injury lasted more than 1 week, and more than that we call it acute kidney disease. We can have acute on top of kidney disease within 3 months, or he can have acute on top of chronic kidney disease if more than 3 months. So this is the spectrum or the terminology of the patient of the acute and the chronic kidney disease. So how you will treat those patients? Surely you have to avoid hypoperfusions. You have to treat the fluids management for such patient, supportive therapy, and the specific therapy. I have a question for most of you. A very easy question. If you have this type of plants, if you have this type of the disease of the plants, and you can see it here, I'm not any in the agriculture, but I can see, I can feel we have different disease for the different plants. If you have these plants in your house, what you will give them? Give me the answer. 1, 2, or 3, or 4. Nobody answered in the chat room. Either you don't have plant, or you, 2. 2, 1, 3, 4. All of them are water. Yes, we have nothing to give for such plants, only water. This is unfortunately. We have different disease for the plants. We are giving all of them the same treatment. This. Any question? Okay, so difficult question, but actually, yes, all of us giving those patients water, giving them fluids, and unfortunately, we are doing like that in our patient in ICU. When you have any patient in our ICU, orogenic, you are giving him fluids. Hypotension, you are giving him fluids. Tachycardic, you are giving him fluids. Metabolic acidosis, hyperlactemia, all of your patients. You can, I can tell you, if you are on call and your team in ICU, your patient developed any hypotension, if he doesn't have vasopressor in his line going on, he can increase. If he doesn't have, he will give fluids. If lactate rising, he will give fluids. If systolic pressure going down, he will give at least 500 normal saline. This is real. This is what happened for our patients, most of our patients. And unfortunately, it is not the main management for most of our patients. So it is harmful. All of us know the trials which is almost kill the early goal-directed therapy. One of them is the PROCESS trial. It is the randomized trial to assess, does usual care different from early goal-directed therapy for mortality, which is stayed for almost 13 years for early goal-directed therapy to tell us it is improving in mortality. So they classify the patient into 3 groups: protocol-based standard therapy, early goal-directed therapy, and usual care. And if you can find here, the highest volume going with the protocol-based standard therapy, right? Apart from mortality, there is no difference between both of them. This is the primary outcome. This is the main objective of this study. But if you look to the cardiovascular event, if you look to the adverse renal effect of the group, protocol-based standard group, you can find the new cardiovascular effect higher with more fluids. The kidneys more worse with more fluid. It doesn't mean the beans doesn't like water, doesn't like fluid. It is not the solution for everything. It can harm. And all of us knows now the fluids have a very deleterious effect for the all organs, right? So even the very old trial, which is the FACT trial, which is all of us know since long time in our ICU. FACT trial, dry your patient. Decrease the mechanical ventilation days, but even the dry patient kidneys will not be harmed, right? So the message, kidneys will not be happy with more fluids, right? So please, you have to think before giving your patient the fluids, right? So either fluids, of course, Clear now, we are avoiding high molecular weight. We are avoiding more than 200 Daltons. No clear data for any other fluids. Using a fluid responsiveness. If your patient is responding to the fluid, you have to use it. If you will not respond, don't use it. Use vasoactive medication, keep MAP higher for those patients who are requiring higher MAP for good perfusion of the kidney, right? Fluid therapy, remember to reduce fluid when no longer needed. Nutrition started early. If the patient needs dialysis, you can start him early. Dose adjustment to prevent actually the harm of the kidney. If you're going to the saline itself, of course, the debating since last 5-6 years now, shall we go with the ringer lactate? Shall we go with the plasmolite? Shall we go with the normal saline? All of them showing normal saline is abnormal saline. Normal saline is no more, almost no more using for resuscitation as much as you can. Not only because it's chloride effect, it can inducing many major injury for most of the vessels, especially renal. So you have to think which fluid this patient needs. Is it replacement fluid? Is it resuscitation fluid? It is balanced fluid? It is normal saline or not? Okay, so fluid management and the fluid type is very essential. And going with the classification of the syndromes, you have to treat rhabdomyolysis, you have to meet tumor lysis syndrome, TTP, glomerulonephritis. Of course, you have to go with each syndrome to treat it specifically. And the complication of the acute kidney injury, of course, you can go through it, hyperkalemia, overload, metabolic acidosis. You have to treat such diseases as early as you can. I hope dialysis, I will not go in dialysis in details because our Prof, Dr. Zainab, she will go in details about which patient need dialysis, when you will start, which mood, what is the dose, how much the flow rate. She will cover everything about such patient in details in RRT. Okay, so just look to these two studies, which is very nice actually, in surgical patient, using biomarker to identify the patient at risk. Over 270 patients. They have like a bundle. It is randomized controlled trials. They avoiding nephrotoxic medications. They avoiding hyperglycemia. They using fluid responsiveness and assessment for fluid responsiveness in fluid management. And unless indicated stroke volume variation, they are not giving fluids for such patient. With this bundle, KDIGO bundle, they classify the patient. Of course, this is the KDIGO guidelines to give you discontinue all nephrotic medication for high-risk patient, ensure volume status, as you can find here in the high risk or stage 1, 2, or 3, with this intervention for the guidelines, and classify the patient actually based on the risk of biomarkers, as we have mentioned early, insulin like growth factor and TIMB2, which is more than 0.3 as high risk, more than 2 as highest risk, with implementing the KDIGO staging for acute kidney injury bundle on those patients. What did they found? You can just take a look in the results. AKI in all of the hospital and surgical patients reducing from 70% to 55%. Significant reduction of all type of AKI. Significant reduction of severe AKI from 44% to 29%. Implementation of KDIGO guidelines. Avoid nephrotoxic medications. Using fluid optimization for the patient who needs fluids and management of the syndromes he needs. Those it can reducing the mortality significantly in all type of AKI. Another alerting automatic techniques in some hospital in Pennsylvania, also by Kellam and his colleagues, Dr. Muhammed, they said clinical decision support for in-hospital AKI. All over the 3 years, they have alarming alerting for all patients in the hospital who patient developed an acute AKI automatically. And you have action, either nephrology consultation, ICU consultation, clinical pharmacist consultation to take action if automatic alerting of those patients, clinical decision support for all those patients. Over 500,000 patients in their hospital, they found 65% of them have acute AKI. And you can find in the first year, they could take it as control. In the upcoming 2 years here, this is the intervention group. So those patients develop the acute kidney injury. We have significant reduction in mortality, even 1%. But over how long? 500,000 of the patients. Or acute kidney injury, 62,000 of such patients. Implementing of just acute kidney injury in the screens, in the walls, and everywhere in the posters. Those patients have acute kidney injury, and you have to take action in such patients. Significant reduction in mortality from 10.2 to 9%, as well as length of stay from 7.2 to 6 in such patients. So, alerting of the acute kidney injury in the all hospital can minimizing the length of stay as well as the mortality. I have two revision questions. This is my last two slides, actually, before I will conclude. Okay, so just share with me. This is just to check, are you engaging with me in the lecture or not? I mentioned all of them. These are only two questions. I mentioned most of them during my lecture. Which of the following intervention has been shown to reduce risk of the AKI? Giving saline, early goal-directed therapy, vitamin C, reducing beptazo, or sodium bicarb? Chat room, AGD, yes, we still have. I will give more 30 seconds for the answers. All of you go. Again, my question, which of the following intervention showing reduce AKI? Yes, 2, 4. Most of you going with 2. Oh my God. I'm feeling depressed. We have mentioned earlier, right? The early goal-directed therapy doesn't show reduction for the mortality of the AKI, right? Risk of the AKI. Reducing nephrotoxic medications. Beptazo, we are not familiar, we don't know that, but in the studies done for pediatric, it's showing one from the most nephrotoxic medication is beptazo. Contrasted the better, it's bigger than that, but beptazo, especially if combined with vancomycin. So beptazo reduction of the nephrotoxic medication, yes, now we start to have answer 4. Yes, beptazo is one of the most drugs you have to take care of, especially if combined with another nephrotoxic medication like gentamicin, like vancomycin, like others. Okay, so reduction of beptazo can reduce the mortality. Great. Okay, so next question. I hope you will have the right answer. You will make me feel happy if you will answer it well. Okay, so the presence of abnormal renal function 14 days after exposure is classified as, I have a patient, we have high creat, less urine, but more than 14 days. We are classifying this patient as acute kidney injury, acute kidney disease, subacute kidney disease, chronic kidney disease. I'm waiting for the answer, please. This is the last question. Yes, Alhamdulillah. I feel happy now. Most of you answering acute kidney disease. Yes, we mentioned the early, within 7 days, acute kidney injury, but if extending more than that, we classify it as acute kidney disease. 90 days, we called it chronic kidney disease. Yes. So thank you so much. I will conclude in brief. Acute kidney injury is a loose collection of syndromes with multiple etiologies. Etiology is often multifactorial. It's not fixed as pre-renal, renal, or post-renal. It is syndromes. We have a clinical science, we have a lab investigations, we have a biomarkers, we have the imaging to go through to diagnose the syndrome you will have. Specific subpopulation, like you have to pay attention for these syndromes: hepatorenal, cardiorenal, sepsis, nephrotoxic. Treatment is therefore aimed to the underlying etiology, not just fluids. Please, not just fluids. Tissue inhibitor of metalloproteinases, as well as insulin growth factor, like growth factor binding protein 7 in urine, are a robust measurement of this acute kidney injury earlier, before we have deterioration in the creat or the urine output. Implementation of KDIGO bundle, fluid optimization, avoid nephrotoxic medications, proper management of such case, research for the etiology in both actually can reduce the acute kidney injury significantly in over the hospital. I had finished. Thank you so much for your presence. Appreciate for all the organizers, for the speakers, for colleagues. Thank you, Dr. Sarwat.
Thank you, Dr. Ahmed. Thank you very much for this elegant presentation. As usual, very comprehensive and very informative. You delivered the hard topic in a simple way. I think I have some questions here in the chat box. Just Dr. Assawi is asking you about the use of albumin in acute kidney injury management.
You see, I'm sure Dr. Adil Hussein will cover, he will talk about diuretics in details, we can comment about elbow, actually. But as a general, I'm not using as a treatment for acute kidney injury, right? But for the cause, yes, I can use it in sepsis, which induce acute kidney injury late after crystalloid resuscitations, right? I can use it. Albumin has another good fact, good intervention, which is glycocalyx. It can save the integrity of the epithelium of all endovascular. So it has a play a role for the syndromes which can causing acute kidney injury. But I don't have experience with using albumin per se for acute kidney injury. Dr. Adil, I think he can, in answer of diuretics, he can maybe have some answer of this more than me, or expert more than me. Thank you, Dr. Arwat.
Okay, another question, Dr. Ahmed, about the N-acetylcysteine in acute kidney injury, not related to contrast. So even with contrast.
Even with contrast.
Okay.
Even with contrast. You see, I have a slide which is no proven evidence for any drugs or any medications can prevent acute kidney injury, right? Even in acetylcysteine, with contrast or without contrast. Only good hydration can help.
Yeah, that's clear. Dr. Ahmed Kuhail is asking about, thank you, Dr. Mady, for the lecture. Are you preferring early RRT for perioperative versus late? I think Dr. Zainab will cover.
Dr. Zainab will cover this. Yes, Dr. Ahmed Kuhail, one from our eminent fellow, senior fellow, and he's very active and he's like.
Yeah.
So Dr. Zainab will answer this question in detail, inshallah.
Yeah, you will answer. Another question from Dr. Fatma. Thanks, Dr. Ahmed. What about placenta previa and renal injury up to dialysis? Maybe she means acute kidney injury related to
hypovolemic. Hypovolemic, I think, yes. Yeah. I think
2-3 days with elevated serum creatinine. How to prevent this intraoperatively?
I think if she means the hypoperfusion because of massive hemorrhage with placenta previa, so you have to optimize intravascular volume using the fluid optimization techniques if the patient is borderline. Again, overt or clear hemorrhagic shock, treat, don't worry, right? The patient's bleeding significantly, give him blood, give her fluid resuscitations, no problem. We are talking about fluid optimization for the query patients. But early resuscitation for such patients, I think you have to augment the intravascular volume to prevent the acute kidney injury.
Okay, this is very clear. What is the single most important to start replace therapy? I can't understand this question.
I think maybe renal replacement therapy.
Yeah, probably high calcium or acidosis.
Yes.
Yeah. Okay.
Again, I think there is a solid absolute indication and relative indication. Dr. Zainab will touch in details. I don't like to go with her lecture actually.
Okay, another question also. What are the precautions with CT contrast necessary with acute kidney injury? He's asking about the prevention.
Yes, contrast-induced nephropathy, one from the most common, most nephrotoxic medications. Actually, it's the highest prevalence of the nephrotoxic medications, especially outside anywhere. But nothing prove how to prevent it. And the good hydrations, we still have some sort of the selection of the contrast itself. No repeating of the contrast within 48 hours, almost if you can avoid it will be better. Talking about sodium bicarb, talking about N-acetylcysteine, talking about dialysis after doesn't prove evidence to prevent acute kidney injury, right? And I don't think we have contrast-induced nephropathy in the surgeon Sarwasa. We don't have it almost in the second day or first day. Contrast-induced nephropathy. It's a good topic actually.
Yes.
We can discuss at the end.
Yeah. Thank you, Dr. Ahmed.